if we take a look at the very first slide, we can say that nothing has changed. Because if we take a look at kidney stones and ureteral stones, it's something that I've already seen 15, 20 years ago when I was a resident. So it's just the same. So if you have a proximal ureteral stone, you can do a ureteroscopy or an ASVL. If it's something that is less than 10 millimeters, it's the same, but it's a SVL or ureteroscopy. And if you go distal, something has not changed. So it's just something that we do for ages and ages. And if we look at kidney stone, what is seen and what is written on the EAU guidelines, we have just a cutoff in between 2 centimeters. So if you have something that is bigger than 2 centimeters, is a PCNL. If you have something that is in between 1 and 2, can be done everything, because endourology is PCNL, is REARS, is ESWL. And if you have something less than 1 centimeters, you can do everything again. So actually, there are no guidelines. So you can do whatever, whenever. And actually, if I can focus your attention on one thing, is that you actually do not have anything related really to the stone, because you have just a diameter. Why we have just a diameter and don't we have a mass, something that say that the stone is hard or not? So it's something different. Because you know better than me that guidelines rely on history. So these are the evidence we took from the last 15, 20, 25 years. So in a period in which we don't have these wide possibilities of lasers, we have the possibility of calculating the hardness of the stone before the procedure. We have the possibility to calculate the volume of the stone. We have just a ruler to put on an X-ray on the wall and say, this is our stone that is that big. So this is why we have this kind of guidelines. So actually, we have this guideline, but our panorama has completely changed. We have the volume of the stone, we have the hardness of the stone. We have to find something that will make an intersection between the volume and the hardness and the position of the stone. In this little part, we have something that is written on the guidelines that say that if you have a lower pole of the kidney stone, something has to change. But it's just a little start. So a very wide view and rapid view on ESWL. We do know very well the history. So at the very start, we had a patient that's starting and entering in a bathroom, actually, to have the water around him and to have the shock wave. And that was really a revolution, because before the ESWL, we have to treat them with a wound long like this. So that was something that changed completely the background. And most commonly, you can see that the problem of ESWL in history, you have a lot of complication that not comes in that time, so before the bleeding, the hematoma, but how the kidney respond to our shock wave. So if a patient tells you that I don't want any surgical procedure because I prefer ESWL because it's complication-free and I will have no problem, is out of the pathway. So keep in mind that ESWL has complication as the other thing. And these are the complications. So if you think that you can have bacteriuria in 23% of your patients, so make it 1 on 4, it's a problem. So if you are shifting to ESWL because I don't want any infection problem on my patient, maybe it's not the right thing to do. Well, at the end of the day, and going forward, my last slide, I can say that the good thing of our guidelines says that you have a wider option of procedure, and when you are discussing the case with your patient, you just can indicate all the procedure, all the pros and cons, and let him choose the right one. These are what is reported on EASWELL guideline, and EASWELL is quite important. Then, if we can shift to rears of ureteroscopy, what is not written on guidelines, and we have completely changed the energy to break the stone. When I started, I have just only ballistic energy, so only an automatic hammer to break the stone. And now, in 15, 20 years, everything has changed. We have holmium YAG, thulium fiber, pulsum tumor YAG, so a lot of other options with different kind of interaction in between the stone and the laser. And so you can tailor your procedure to the patient. This is just a very teeny slide that allows you to understand how wide is the field of the laser and how strict is the field of holmium and thulium. So they stay just here, but you have plenty of laser. Tomorrow we will have the BPH. BPH for a lot of years had the green light laser that stay into the visible part of the frequency. So it's something very wide. And our EAU guidelines do not rely on this, just rely on something that was before. And these are all the variables because you have different laser and then you have different modulation. So you can have continuous wave, you can have the modulated one, you can have the faster modulated, and then the super pulse, the one that comes out with the thulium fiber. And then we have the something that is merged, the YAG with the thulium fiber, which is the new release of Quanta de Magneto. So you have plenty of option to treat the stone. And you cannot have only the diameter as a variable to choose how to treat the patient. You have to rely on volume, you have to rely on position, you have to rely on hardness of the stone. And these are the different settings you can have if you rely on, sorry, should it be a video that starts? It's a loop video. And these are, oh, beautiful. So if we take a look at these are the different interactions that you have with the bubble production and the stone you have in front of you. So you have the normal pulse with just a bubble. Then you have the vapor tunnel that is beautiful if you're acting the ureter, because if you can see the vapor tunnel is just cylindric as the ureter is. And if you can go on a little bit, so I can speak on the images. And the virtual basket, you have two bubbles. The one that brings the stone against you, and then the second one that treats the stone. So, and there are plenty of works that rely on different settings for the same laser. So you can have just one laser, but you can adjust the same laser with different settings. And then we shift to the super pulsed. So you can lower down your energy, you can add a very higher frequency, like an automatic weapon. So you're just using a very low energy, so less complication, speaking about all the tissue around, but a very high power of dusting and disruption of the stone. For sure, you have to know how hard the stone is, and this not come out from the diameter, but come out from a good interaction between you and the radiologist. And in the perfect world, you will come out with a CAT scan with the stone that has a volume and hardness, and the radiologist say, this is the stone that should be treated in this way, and you just treat that way. This is just to show you how it goes, and what are the complications. So we are now working on that, and there's a company that comes out with the ureteroscope that actually measure the intrapressure that you are having into the kidney. So try to be not an high frequency inside the ureter, and you can go up with your frequency. You have treating a stone inside the bladder, power and frequency up. So it's something that is not inside the EAU guidelines, but it's something that anyone that is facing a stone patient should know. These are the recommendations. These are the ureteral sheet, anyone, and just a little spot on the PCNL, and I've finished. So there's no any mention about mini PCNL, ultra mini PCNL, micro PCNL into the EAU guidelines. And we do not know in that gray area of 1 centimeter and 2 centimeter what to do. So this is why there are going out a lot of papers about saying, what can I do if I have a stone in that range of diameter? And actually, is that range the thing that I have to look, or is something about the hardness, is something about the volume, is something about the position? So, just to make the take-home message could be this one. Starting, I say that what has changed in EAU guidelines about the lithiasis, and I said nothing. What should be changed in the EAU guidelines on lithiasis is a lot. I can tell you a lot, and maybe everything, because we have to rely on the energy that is used, we have to rely on the stone, we have to rely on the position. Thank you.
Thanks, Giorgio. Is there any question from the floor to Giorgio? Yes, Javier?
I have one.
Can we bring a mic to... Is anyone here from the organization to bring a mic? If not, you can use this.
In my department, we are doing only 40-50 external wave lithotripsy, and we are doing more than 600 ureteroscopies. And I asked to the people of my department why are not using the shockwave lithotriptor external, and they give me no answer. So I don't understand why we have the lithotriptor they are paying the lithotriptor, wasting space and time. So can somebody explain to me why are we still having a lithotriptor that is expensive and nobody wants to use it?
Because, well, we know actually why we are not using more the lithotriptor is a matter of how many procedures you need to have a stone-free patient. That is the same answer about why the rears is losing a little bit of rate of patient and mini PCNL is getting wider. Because we need a higher stone-free rate in less time. As well as a great advantages compared to the open surgery. But if we rely on how many procedures, how many complications, how many renal colic do we have in a patient, sometimes it's better to gift him a surgical procedure, an endourological procedure, and to treat the patient one time.
So lithotriptors are going to disappear?
Maybe not. The future, I cannot see the future, but I can forecast. And my opinion is that you should have, in a country, in a region, at least 1 or 2 lithotriptors, 1 in 1 million people or 2 for 1 million people, just to treat that patient that could not do or do not want to do any surgical procedure. You should have an option in 1 or 2 centers for any big area, but it's nothing that will have that wider use we used to have 10, 20, 25 years ago.
Okay, I have another question
Yeah.
before connecting to the ORs, and it's a question probably related to future, what the future holds, Giorgio, regarding indications, because you see that guidelines only tell you, well, you can do almost everything to everybody,
Yeah.
and there are a lot of gray zones, and the gray zone is very, very, is huge. It's huge.
Yeah.
And what do you think if the future can help us regarding predictive variables and putting them in a artificial intelligence machine, for instance, that gives you the odds of rendering a patient stone-free without complications, if he has probably 7 or 10 variables that should enter into this algorithm, but today they cannot enter algorithm because we don't have evidence. What do you think?
So the problem, as you told us, is the evidence. So we have a very short amount of paper that speaks about mini PCNL, hardness of the stone, volume of the stone. Well, the future will be this one. So you will have an indication according not only about the diameter, but merging together position, hardness, volume, diameter, and then merging all the things together, we should have an indication, a number that tells you with an higher rate you can have a stone-free rate with this procedure, and lower you can have with other procedure. You cannot tell with the guidelines you should treat this in this way anytime, but we will have a more complex algorithm that says to you, if you have this stone that has 5 as an index, we can tell it that merge together variable like position, hardness, volume, you can treat it with this thing. And speaking theoretically, we can say that the future is the miniaturizing of all the things. So we are going to mini PCNL, micro PCNL, something that is very, very thin. We started with this big ureteroscopy, semi-rigid ureteroscopy 25 years ago. Now there are on the market disposable, flexible ureteroscopy 6.3 Charrier. So very, very, very thin. So this is the future, to have a better consciousness on the stone, a better consciousness on the laser you are using, and a better consciousness of your instrumentation.
Okay, thanks, John.